Hello, my name is Matt Wolf, and I am a Director and Healthcare Senior Analyst at RSM. RSM is the leading provider of advisory and accounting services to middle market firms globally. Here in Tennessee, we have been serving our clients in industries like healthcare, consumer products, real estate, and business and professional services for many years. About 2 years ago, we made the strategic decision to invest in this community by opening our first physical office here in Tennessee. Fast forward to today, and we have over 50 professionals here in the local market helping our clients grow and navigate these challenging times. As part of our commitment to the community, we're also very pleased to be part of HIMSS 2020. And I get the distinct pleasure of introducing our moderator, Robert Chamberlain. Robert directs company vision and leads strategic partnerships and investor relationships. He is a veteran executive and noted entrepreneur with over 30 years of experience working with employers and health systems across the United States. Robert is a frequent speaker on entrepreneurialism and successful payer-provider partnerships and has authored numerous articles and has appeared in publications such as The Tennessean, Healthcare Financial Management Magazine, Benefits and Compensation Digest, Health Management Technology, and Modern Healthcare. Nashville Business Journal named him a 2017 and 2014 healthcare hero, and Applied Health Analytics one of 2014's 30 fastest growing small businesses. The company was also selected as a 2017-20 most promising data analytics solution provider by CIO Review and named a finalist for the Nashville Area Chamber of Commerce and Entrepreneurial Center's 2014 Next Award, which celebrates excellence in business and entrepreneurship. Please join me in welcoming Robert and the rest of our distinguished panel.
Good. Well, hello, everyone. I'm Robert Chamberlain. I'm Chief Executive Officer of Applied Health Analytics, and it's a pleasure to moderate this panel of three very distinguished individuals. And we're going to start off with one of my favorite. Her name is Ruth Christopolsky, and she's Senior Vice President of Population Health with Atrium Health in Charlotte, North Carolina. So good morning, Ruth. How are you?
I'm very well, Bob. Thanks for having me today. Really excited about the discussion.
Well, I know you're busy, so thank you for joining us. Let me start right off, if you don't mind, because I know that Atrium, being the very forward-looking organization that is has engaged in direct-to-employer strategies for some time. Can you talk a little bit about why you initiated these strategies and how it's evolved through the years?
Sure. So Atrium Health has actually had an employer solutions construct for more than 30 years. So we've been working in the employer space going way back, and the intent really was to develop a front porch for our employer partners in order to engage Atrium Health, and really started as the delivery of specific services. So whether that was biometric screenings or health fairs, flu shot clinics, so more of a transactional based interaction. And then over time, really started thinking about how do we partner differently with employers to solve one of their greatest needs, which is keeping their employees healthy and trying to help them control their healthcare spend. So over the last decade have really offered additional services, including on-site and near-site clinic constructs, and we're working on direct primary care and really trying hard to become a partnered organization with the employers to meet their needs and move away from more of the basic transactional services.
Great. Well, the employer, particularly a self-funded employer, is the payer, and we've known for decades the cost of health benefits have only gone up. Have they turned to you differently in more recent years in what they're expecting or what they'd like to see you deliver to them?
Well, I can tell you prior to COVID, we set out on about a 6-month journey across our footprint, sitting down with employer partners, some that we already work with, some that we potentially would like to work with in the future, and spend some time with them understanding what their needs were, where their pain points were and how we might be a solution to them. Some of those pain points were around cost. So, what it costs to deliver a particular service or a set of services, or in some cases, the total cost of their employees' health care coverage. In other areas, areas that we were really surprised we heard about was help us help our employees navigate your system better, right? There's so many places to enter, and we get bigger, we consolidate more, and then we think we're making it easier. And quite frankly, what we've done is complicate how people enter the system. So we heard a lot about navigation and entry. And so as we're developing products, we're really thinking about how do we ensure that we can provide price points that make sense for the employer, plus help the employee navigate the system in the most efficient and effective way possible. So that's what we're looking towards as we develop our strategy, both for this next year and the next 3 to 5 years.
And I know that Atrium Health owns, is it 1 or 2 TPAs?
We have 2 actually TPAs that are part of our organization. MedCost that covers Virginia, North and South Carolina, and then we're also a part owner in a network and a TPA in Georgia through our Navicent integration. So we actually have 2.
Well, those are very interesting capabilities and resources. How do you see them playing into your relationship with employers today and going forward?
Well, I think, and I'll speak specifically to MedCost. I have a lot of experience. I actually sit on the MedCost kind of board, and so understand their operations maybe a little more deeply. But MedCost historically was thought up to be a flexible, right, regional and more local answer for employers in developing and deploying meaningful benefit packages for their employee base. So really, really flexible in benefit package design and having a real customer service orientation. I think our next step from an evolution standpoint is to start to think about how do we begin to build or offer benefit packages that are enhanced to the employers that we work with, that offer services that help reduce cost and bring value. As an example, integrating virtual healthcare services into benefit packages instead of bolting it on, to the side of a benefit package. And then really looking at how we can put together constructs around centers of excellence and high value networks, and using MedCost as the delivery vehicle to our local and regional employers through that framework. So really excited with the Wake Forest Baptist merger. We're going to have the opportunity to do some more creative things across the broader footprint with MedCost.
Great. Well, as you well know, benefit consultants or brokers are highly regarded by their employer groups as advisors and consultants. Some can see them as an obstacle, others can see them as an opportunity. Does your conversation with the broker community change relative to your conversations with employers?
Well, I think, we've had a really focused process around including our broker partners in our conversations in both how we're developing products and products that they would see as valuable and beneficial to their employer partners, as well as we're having conversations with the employers, many times having the broker at the table. So we've had them as part of our employer conversations, but I'll be honest, we've actually, with some of the larger brokers and consultants, had separate conversations with them about how we might be a solution for the employers that they represent. And so I think our thought process is that by being inclusive and figuring out how we can solve for everyone, all boats rise, some of our clients really need their broker partners because they don't have internal resources to understand how to best meet the needs. Others have, benefit departments that are really large. And so figuring out how we become part of that team, right? So how do we get invited to the table to help solve? I think when we get that figured out, we'll have succeeded.
Well, Ruth, on a similar but somewhat aligned vein, I was on a conference call not too long ago, hosted by private equity firms and a couple of venture capital firms, and they were talking about the amount of dry powder that is on the sidelines, and it's somewhere on the order of $1.6 trillion in the coffers of these organizations that are looking for investments in healthcare. And much of the discussion was around groups like Oak Street Health and One Medical and Paladina Health. But I wanted to ask you a question that gives me concern about the investments health systems are making in their primary care perimeter. For example, Walgreens has recently made a $1 billion investment in Village MD. They intend to open up 700 clinics in 30 states across the United States, all staffed with PCP or mid-levels. And CVS is launching 1,500 health hubs, which are intended to manage chronic disease, provide behavior modification services, provide concierge PCP capabilities. And of course, the merger with CVS and Aetna is very, very interesting. But the point is this, both of those organizations are largely focusing on Medicare Advantage or the Medicare population. But I'm convinced it's just a matter of time that they jump the firewall and they go to the commercial market and they say, look, combined, Walgreens and CVS, we have over 15,000 locations across the United States. That's a pretty impressive network. So if they're making these investments and they're moving the primary care perimeter closer to the consumer in a retail environment, does that concern you? And if so, what's your response to that?
Well, of course, all of these pieces are in play, and with the U.S. economy, having 20% of it represented in the healthcare space, the fact that there are a lot of dollars playing in that space isn't surprising, since there's a lot of dollars spent in healthcare. I think that there's a belief, particularly in some of these models, that running primary care, not in the short term, but for the long term, is easy and very profitable. And as somebody who's been doing this for 30 years, I've worked in systems that have been integrated, including large primary care footprints for the majority of my career. Investments in primary care grow over time, right? And there's some value to co-location and directing and capturing dollars from the healthcare consumer that you might get with a CVS or a Walgreens. That makes sense, but I always believe that integrating healthcare, right, bringing all of the people that need to care for individuals, keep them healthy, and when they're sick, take care of them together, right, across the community where information is shared openly and visible to everybody that's playing, is that there's an extreme value to that. And what we see with all of these different entities is further fragmentation of healthcare for the consumer. That might work well when they're in the small microcosm and in a clinic at Walgreens, but doesn't work real well when they need 4 or 5 or 6 or 10 other things. And so I think we as healthcare systems need to understand that these things are happening because we're not meeting consumers' needs. So whether it's access, right, whether it's convenience, whether it's price point, we've somehow missed the mark in our delivery of primary care, so that others feel that they have the capacity and ability to come in, right, and fill those voids. And so it's a call to action to me, to be very honest, Bob, to think about how do we ensure that what we're offering meets the consumer needs and preferences of the communities and patients we're serving, and to ensure that, we have the best access, the best quality, right? An agreed upon value-based price point, so that we become indispensable, to the consumer. So I think this will all play out. We've seen roll-ups before in healthcare, the 90s and 5-4 and all the roll-ups of the clinics that's in disintegrated. We're now seeing kind of the roll-ups around the patients and the valuation of each member. We saw some of that in, health plan plays and consolidations, in the 90s and 2000s also. So I don't think any of this is completely new. It's a different flavor of, but I think it's a response to, people wanting great access, right, convenience, and a price point that's affordable in primary care. And we as healthcare systems have to make sure that we're delivering that.
Thank you for your time, and we're getting ready to hear from a colleague of yours, Dr. Bill Satterwhite. So, Ruth, thank you for joining us today. Joining us this morning is Dr. Bill Satterwhite, who is the Chief Wellness Officer at Wake Forest Baptist University in Winston-Salem, North Carolina. And I can only describe Dr. Satterwhite as a Renaissance man. He's an attorney turned physician, turned entrepreneur, and has some really insightful guidance for us relative to Wake Forest Baptist and their employer strategy. So good morning, Dr. Satterwhite. How are you?
I am doing well. Thank you for inviting me today, Bob.
A question relative to COVID, because our experience with your team is you guys are very creative, you're very agile. What has been your response to employer demand for COVID-related services?
Yeah, COVID was really fascinating, for all of us. What happened for us is while a lot of the clinical service lines were slowing down and furloughing and all this as the stay-at-home orders hit, our business actually surged. So in April, May, June, we wrote more new business in those months than we did the whole year before, because suddenly all these people in critical industry were working like crazy because a lot of supply lines and other things had fallen apart, and so now they were getting more work, and they needed help. They were like, are we supposed to be a healthcare facility now? What is the deal? And they suddenly realized the value of our presence. So, for example, in one situation, we literally set up an on-site clinic in 2 weeks from when they asked us. And the other thing we had going was lots of in-person temperature screenings and surveys given, the CDC had their questions that sort of evolved over time. And so we had many companies paying us thousands of dollars to staff these, some 24/7, trying to help them keep any germs from sneaking in and causing them to shut down. Now, in terms of the creative side, we also realized that is unsustainable. We were dying on the labor side, trying to staff all that. The employers are like, how many thousands of dollars am I paying you to, have somebody ask these questions? And so what we did was we said, there's got to be a better way, and I think we can figure that out. And so we used a partly owned startup that has blossomed out of this place called Winston Starts, which is a bit of an incubator here in Winston-Salem for startups. And Wake owns part of that. And we said, let's take that and run with it, because they're in the health tech space. And what we were able to do was to design a web-based symptom survey tool that is phenomenally easy and has incredible features like daily text reminders, works on any device, clears people instantly if they're fine, and gives them a screen and a thumbs up sign that says go to work, and here's the date stamp and the time on it. If they get flagged, the screen stops them, and they get an easy button. And there's triage, which most of the time is us, though it doesn't have to be. The employer can pick who or what they want, and then it's got real-time dashboards on the back end.
I'm sure they would love to reach out to you and learn more about that particular capability. How would they best contact you?
The easiest way probably is to go to the website, and so it is www.sneezesafe, and that's sneeze with no E on the end, SNEEZ, and then the word safe, SAFE.com. And there you can just contact us, and we're happy to talk. It is truly scalable anywhere.
In a similar vein, we all know that employers are the largest single payer for healthcare services in the United States. You clearly have started down a path with a number of employers in the greater Winston-Salem area, and I would say probably most of Western and Northern North Carolina. Do you see the quality or the intensity of these relationships, or these conversations you're having with employers change? And as an addendum to that, do you see the relationship between the payer, again, the employer, and the health system becoming more close?
Yeah, I would say short answer, yes and yes. It's really interesting if you think about the health system that we have in the U.S. Many people think that the health systems and the doctors created the current payment model, the employer-funded healthcare and insurance and all that. We actually didn't. That actually came out of the employer lane. And so the point of that is to say it's up to employers to change it, and they can. Right, so the law allows them to have huge flexibility in terms of how they design benefits. It's all under that big law called ERISA, which everyone knows about. Most employers with 100 or 200 or more employees are going to self-fund, and ERISA just says, well, if you're going to give them, this is sort of the rules around the game, and so the opportunity there is huge now that all of these companies are doing the self-funding path to realize we're actually writing those checks. What are we getting for that? How should this be different? And so I think that pathway is wide open, and I think that there's going to be more and more direct contracting, I'll call it, between health systems and companies, because in all candor, if you sidestep the sort of claims filing pathway, there are two benefits that flow to you. One is you typically save 30% right off the top in just the cost and the churn for the same service. And the second one is that you actually get to really design what it is you want that care and that plan to be like. And sometimes I'll tell friends of mine, especially the business community, healthcare is the only industry in America where supply tells demand what to do. That's typically how it works. Yet when you shift to a direct pay, direct to employer kind of agreement, then the employer is clearly the purchaser dealing directly with the supplier, us in healthcare, and now demand gets to say, this is what we want to do, with a few legal guardrails. And so I think that is wide open and going to happen more and more and more. And as health systems get bigger and consolidate, that'll actually be easier. When they're all just tiny and local, it's really hard to meet the needs of businesses that are beyond that little town footprint. So that's kind of how I would phrase that. I can go deeper if you want, but let's stop there.
Well, actually, I'd like to unpack that just a little bit more, because you recently co-authored an article with Barry Heron, who's an attorney out of Atlanta, dealing with ERISA. Can you and there are aspects of the ERISA law that I don't think a lot of people are aware of. Can you unpack that a little bit and talk about how ERISA actually benefits health systems?
Yeah, so ERISA really is a game changer, and most people don't realize it. It came out, I want to say 1973 or 74, was mostly about retirement plans, and then gradually was broadened to include things like medical care that an employer is paying for. And so that's where it's landed. There are probably two key things to note about ERISA. The first is that ERISA actually lets employers design multiple medical plans. And by that, I don't just mean, we got option A as our major medical and option B as our major medical. It lets you layer on top of those other more focused, specific health plans, or in the language of the law, it's welfare benefit plans. So for example, you could say, we're going to design a specific benefit, employer-funded benefit, that addresses all the people who have type 2 diabetes. And here's what we're going to do. So if you have that, and maybe you define it as a hemoglobin A1C over 6, whatever number you pick, 7, doesn't matter. You say, these are the benefits that group gets. We're going to have a designated diabetes educator available 24/7. We're going to have no copay for any drugs related to diabetes. We're going to have no copay for office visits related to diabetes. They can design the whole thing like that. Now, that becomes either another separate plan. You can do it two different ways. You can set up as a whole separate plan, or you can just amend your summary plan document, frankly, and say, this is the benefit for these people. So imagine for a moment what the power of that is with your spend, right? Because right now what happens is most health plans are a one-size-fit-all plan, right? And that'd be like the employer saying, we're going to buy everyone a pair of socks this year, and here it is. And you'd be like, my foot can't fit in that. Or somebody else will say, I'm swallowed by it. That's worthless, right? And that's what we tend to do with healthcare. And so it doesn't really work for very many folks. What you can do under ERISA is tailor the plans and say, we've got a targeted plan for people with diabetes or diabetes and hypertension, or we've got a targeted benefit offering for people with mental health disorders, and this is how we're going to deal with them. So it becomes phenomenally powerful. That's one part of it. The second part, which I guarantee you nobody knows, is that ERISA preempts all state laws that relate to benefits, which means that it preempts the state insurance laws that say you have to have an insurance license to take on risk. So in this particular context, if a company said, hey, we want to contract with you, Wake Forest Baptist Health, and we spent $7 million on healthcare last year, we're going to give you $7 million to care for our people next year. Have at it. We could actually do that as a health system without having to get an insurance license and be an insurance company. And that's something not that many people know for some reason, but it is 100% available, which suddenly transforms the whole value play, right? Many times health systems struggle with this move to value because most of it's in like Medicare Advantage, and it's still all in the insurance lane and who's attributed and this and that. And a lot of that stuff doesn't really work when you're talking about employers, in part because the population is usually smaller. Many have a handful of thousands of employees, not 40,000 lives covered by one of the big carriers. And the other reason is that the attribution idea is hard. It doesn't always work as well in that corporate setting. Now, if we were going to take on all of that and say we're going to care for these people, then obviously they'd have to go with us, right? We're the contracted provider. So it would sort of work the same, but ERISA has tons of powerful opportunity for both the employers and the health systems who are, creative enough to actually really think about that and to go for it. And certainly they could look at that article at Barry Heron's law firm site. I think his law firm is heronhealthlaw.com, and could actually read that and go, aha, maybe we should head down this path. It's incredibly powerful. It's actually what the marketplace needs, frankly, both for health systems and for the employer. It's actually possible to create, a win for the patients, a win for the health system and providers, and a win for the company, which is actually what we all want, right? That's like why I'm here.
Well, if I'm a carrier, I'm going to be concerned about that movement, but clearly it's a game changer. It's a game changer, and it truly gets health systems into the healthcare business.
Yeah.
That's very, very interesting, Dr. Satterwhite, and it's certainly sparking a lot of thought here at Applied Health Analytics. Well, Dr. Satterwhite, I know you've got a ton on your plate. You've been very generous with your time this morning. Thank you very much, and
pleasure.
Look forward to staying in contact with you and learning more about what Wake Forest Baptist is up to. Thank you, Dr. Satterwhite.
Thanks for letting me be here.
Well, I'd like to thank Ruth Christopolsky with Atrium Health in Charlotte and Dr. Bill Satterwhite with Wake Forest Baptist in Winston-Salem for their input on the panel thus far. And joining us this morning is Dr. James Porter, President of Deaconess Health in Evansville, Indiana. Good morning, Dr. Porter.
Good morning.
Great to have you here, and thank you for joining us this morning. I wanted to start a little bit by talking about Deaconess Health and your interest in launching a commercial strategy, and why is that important to you?
We felt for a long time, Bob, that the closer providers and the people paying for healthcare can get, the better off we're going to be as a healthcare industry in the country. Not that there isn't a place for insurance and other what I'll consider middle people in the transaction, but certainly there's an opportunity for waste in that part of the equation, and we think that being more specific and directed as to meeting the particular needs of employers in the community is something that we can do best, working as close to as directly with them as we can get.
Well, I know you have a sizable footprint in southern Indiana and western Kentucky, and I also know that you're very, very involved in the community in the greater Evansville area, specifically with your involvement in the Chamber of Commerce. So when you're with your peers as president of one of the largest employers in that particular region, what is the conversation that you tend to engage with these people around population health, if you would, and what sort of requests or demands are they having from you as someone who's the leading provider in the market?
You know, for a long time, employers were pretty hesitant to engage in conversations, especially around directed care or narrow networks, which is a pretty important part of the equation if we're going to find ways to work more directly with employers. We're seeing that start to shift more than we had in years past. And I think now employers are willing to think more about working on a more exclusive level with a particular health system if they see opportunities to generate savings, because the primary concern that we hear from employers is cost. Certainly they're concerned about the health of their workforce. I think they feel like they can address the health of their workforce with a number of different partners. So cost really rises to the top of the list of things that they're trying to get at. And, you know, what we often are telling them is we will be able to help you with cost, but part of the equation is we need to figure out ways to get more of the patients from your organization into our services for us to be able to deliver that savings on cost.
Well, as you mentioned, there are a lot of organizations that are in the population health space. What advantages, as the local healthcare provider, what advantages did Deaconess Health have in this market?
Well, I think a number of advantages. One is we know the people, we know the market, and as the dominant provider in the region, we have the most facilities, we have the most locations, we have the best access. You know, one of the things that I'm proud of that we've done at our organization now for some time is try to become a lot more rational about how we do price our services. So when we look at things like imaging and lab, outpatient access, we realize that there are either already competitors present in the market who are looking to undercut big organizations like ours on price, or the likelihood is that they're coming. So we've been over the years trying to get our charges down to a much more rational level on things that we consider more commodity type services. But the benefit of that is one of the hidden costs in healthcare is fragmentation. And the more different competitors that come into the market, the more cost we see driven by lack of communication between providers, unavailability of tests, or tests that aren't compatible with what exactly the provider needed or was looking for. We can help employers avoid a lot of those hidden costs because we do have a fully integrated electronic medical record. Our providers are communicating well with each other on a regular basis. And when we have tests and procedures performed within that space of our providers, our locations, and our EMR, we can be much more efficient with how we use those resources. So we've got the price down to where it's competitive, and then we can layer in on top of that, I think, much better functionality for the employers as well.
No, as I said, you're very active in the community, so you have the relationships, you are the trusted brand. You clearly bring to the table the technology necessary to be successful, so congratulations on that. I also want to congratulate you for, gosh, over the past couple of years, you've had one of the highest performing MSSP plans in the country. So you've been able to demonstrate your ability to competently manage a Medicare Advantage population. Do you see bringing a similar capability into the commercial market?
Yes, and we've actually done that this year. So we've partnered with and actually become part owner of an insurance company, a regional insurance company here in Indiana. And part of that has been to introduce a new Medicare Advantage plan to our region called My True Advantage. We do believe that the capabilities that we've developed in the next generation ACO, where, as you point out, we've generated some of the highest savings of next generation ACOs in the country really since the beginning of that program now. We think that there's a direct correlation between managing that traditional Medicare population and managing a very similar commercial Medicare population. So we're really excited about being able to get into the Medicare Advantage space, and I think do it in ways that we've struggled to find the right partnership, frankly, with a lot of the commercial options that are out there. Those have often been frustrating relationships for us. Understanding, how a lot of the quality metrics are calculated, how some of the incentives are determined, has often felt like a black box to us. And we now have full vision into MyTrue Advantage as a plan, and we think can not only make it work better for Deaconess, but make it work better for other providers in the state and the region who probably are looking for similar opportunities.
Yeah, that's very interesting. So you mentioned employers are interested in managing expense. You're starting to look a heck of a lot like a carrier. Do you envision someday entering into risk-based contracts with employers?
Yes, and in fact, we're already, we have some examples where we've done on sort of a limited basis certain types of risk, and we have a number of conversations even going on right now with employers who, as they're willing to entertain the possibility of narrowing the network of providers, they're also wanting to layer in on that conversation a discussion about how might we put some skin in the game, if you will, and start to provide some either corridors where we could control the amount of risk that they have year over year, or potentially even taking some direct risk with upside and downside potential.
Yeah, that's interesting. The people that seem to be making money in healthcare these days are the middlemen, the carriers, the PBMs, to a certain extent, benefit consultants. It's said that 26% of the total cost of healthcare is in those three categories. Given employer interest in managing expense, do you see the opportunity someday in the future, envision the opportunity of going to these employers and saying, we're the provider, you're the payer, let's enter into a hand-in-glove partnership? How can we work together to more efficiently deliver care in the Evansville, Indiana market?
Yeah, and I think we're already having and have been having those conversations. You do need, in the middle of that transaction, in most circumstances, a third-party administrator, just because in order to be able to keep track of where are the expenses and how are you performing and what is utilization like for a certain group of beneficiaries, it's hard to get away from a relationship that doesn't in some way include a TPA. We try to be fairly agnostic about being able to work with TPAs, but as you know, some TPAs perform better at providing data than others, and that becomes a pretty important component to that part of the relationship. That's another reason why we felt like it was important for us to get closer to an actual payer, and one of the reasons that we invested in the insurance company that we invested in, because we believe that having a really solid relationship with a third-party administrator and having a pharmacy benefit manager that you trust and that has transparency and that you can have influence over things like the formulary, that then all becomes really the recipe of all the necessary components to do what without, essentially it ends up being almost a direct to employer type of option, but it's a health plan that's a provider-owned health plan.
Yeah. Good. And my apologies. I think I moved Evansville from Indiana into Illinois. So if you wake up in the morning and your bed's in a different place, you'll know why.
Illinois is part of our service area, and a very important part of our service area to us. We really serve Southwest Indiana, Southeastern Illinois, and Western Kentucky, and the majority of our regional referrals actually come out of Southeastern Illinois.
Dr. Porter, one last question. Tell me about your go-to-market strategy. How do you approach the employer market from a sales and marketing perspective? And are you working with brokers to help sort of make that channel more efficient?
Yeah, in our market, and I think this is true in a lot of places, at least for the foreseeable future, you almost have to work with the brokers. A lot of those relationships are long-standing relationships, and that's where a lot of the trust is. We find that so many HR leaders within even larger organizations feel pretty uncomfortable in the healthcare space. and they lean pretty heavily either on their broker or on a consultant or a combination thereof. And so we need to be able to work with those folks to find solutions that will work for their clients as well. I think the conversations are sort of self-starters. We aren't really doing a lot of what I would call marketing, in that we're advertising to places, hey, come to talk to us about what we can do to help lower your healthcare costs. We're having those conversations really, more one-on-one. And as you said, being part of the community really opens the door to those kinds of discussions. And so we do have folks who it's their job to go out and interface with the different employers in our region, and really to talk with them about a variety of solutions that we have. For some employers, really the best place to get started is something like an on-site clinic, where you start to develop your relationship around that focal point, and then other opportunities can grow from that. For others, they're willing to jump into a more narrow network type health plan, and we can layer on then other solutions that we provide around wellness, around workers' comp, on-site, near-site clinics, pharmacy consultation. So there are a lot of things that we can then start to layer on, which I think creates a menu of really interesting opportunities for the employers, and really then finding which ones fit their situation best and being flexible about how we put those into a bundle, if you will, for them, I think is where we're going to see the most traction in the next couple of years.
So in closing, you have leadership in your market, you have the tools, you have the levers. If I'm a carrier, should I be concerned? Oh,
I think the large carriers still have, the lion's share of the market, and will for the foreseeable future, barring some kind of, national legislative intervention that would start to have an impact on that. So no, I don't think the large payers really have anything to be concerned about. They have a significant market, and there are a lot of employers that are just in so many different geographies. The way the laws work right now, they pretty much have to work with a large national payer.
Dr. Porter, congratulations on what you've been able to build. Brings an end to our panel, and we're going to open it up for questions. So, Dr. Porter, thank you very much.
My pleasure. Thank you.